live. And then we can give it like 2 to 3
Also, if
minutes.
there are any questions, can you just like ask me because I usually don't look at the chat.
Yeah. So I'm gonna have to ask you anyway, since like only I can see like
Oh,
YouTube screen. Hold on. There we go. So then like we'll wait for a few to let like people come. But so what was your favorite part of today?
doing the chest tube.
The chest tube? Sounds kind of scary.
Yeah, you always think you're gonna hit the lung, but I mean, if you hit the lung, that's the treatment, a chest tube. You hit the lung, you cause a pneumo or air in the lung. The treatment is a chest tube, and you're already doing the chest tube. So technically, you're kind of safe there
Yeah.
to an extent.
That
But
makes
yeah,
sense.
yeah, it was for a big effusion. This patient had like just a ton of fluid in their chest, and they weren't clearing it with a medication that we give to help them pee, which is normally what we do. They weren't clearing it, and their chest X-ray had like a huge whiteout, like the whole right side was just whited out. So in terms like that, we get an ultrasound, like a bedside ultrasound, and look to see if there's a lot of fluid, and if there's free floating lung, we call it the jellyfish sign. Then in that case, we can safely go in with the needle and take back the fluid. So
Oh,
with that, we did the needle, but then we stuck a guide wire in, and then we put a pigtail catheter in chest tube. So that
oh
was cool.
wow. That sounds complicated, but yeah, really cool. Um, Hello to everyone. How are you guys doing? Um, I'm just gonna start off with a little like disclaimer side thing. Remember to stick around for the whole thing, and then in order to get credit for your for virtual shadowing, you guys can write up a summary, 4 to 5 sentences, and send it to our email, and you should be able to get a certificate from that. Make sure you read the guidelines and stuff. They're in our Instagram bio. So that's just a little background. But today we have Dr. Nina, and I will let her go ahead and introduce herself.
Hey everyone, thanks for tuning in today. My name is Nina, Dr. C, and or Dr. Chandrasekharan. That's what I usually have my patients call me, just Dr. C, because Dr. Chandrasekharan can be very long. I am pulmonary critical care. That's why you see on the screen PCCM. That is our abbreviation. Basically, a little bit about me. I grew up in South Florida. I did my high school there, well, elementary, middle, high school there, and then I did my undergraduate in South Florida as well. I did my medical school in the Caribbean, American University of Antigua, so AUA. And then I did my clinical rotations my third year in Florida, where I'm from. My fourth year, half of it in New York and half of it in Florida. I did my residency for internal medicine in University of Pittsburgh Medical Center, UPMC. So I am internal medicine board certified, and I am now doing my fellowship in pulmonary critical care in Detroit. So a little bit about pulmonary critical care. Pulmonary, as you know, is the study of lungs. So we're lung experts, is what they say. And then critical care is the ICU. It's the intensive care unit. The sickest of the sick patients come to us. We manage airways if they cannot breathe. We manage their breathing status. We manage their breathing status on a ventilator. So we manage patients on the vent through vent settings and their acid base status, which we'll get into a little bit later. If patients are requiring medication called vasopressors to help keep a blood pressure because they're not perfusing their organs, we manage that. We manage all sorts of organ failures, sepsis, septic shock. So basically the sickest of the sick patients come to us. So it's fun, it's scary, it's exciting all at the same time. And I apologize for looking like I just woke up, but I just got back from work a little while ago, showered, and here I am. I've been in the ICU actually today all day, all month. We have to wake up at 5 every day, 5 a.m., and we start at 6 a.m. in the ICU. We usually go to like 7 p.m. I do post a lot on my stories of things that I see. So if you guys follow me there, you can kind of follow along on my days. But so if you guys have any questions, definitely feel free to ask me and we'll just jump in right away. So we have a case here today. This is one of our Oh, sorry, I just muted myself. This is one of our first cases. This is a 32-year-old female with history of diabetes. DM is diabetes mellitus, HTN hypertension, comes to the ER for shortness of breath, SOB, shortness of breath. She is very tachypnic on exam, diaphoretic. Tachypnic is just when you're breathing very quickly. We call that tachypnea. So this patient was breathing very quickly, and diaphoretic, meaning she was sweating a lot. And that can sometimes happen if you're just using your body to work. You just get so tired that you start using your accessory muscles and you start just not being able to keep up and you start sweating. So cannot elicit too much information from the patient. So husband is with the patient, comes in and says that they were at a party last week. VS are vital signs. This is one of the first things that I look at in ICU when I first assess a patient. And this is something almost any doctor first looks at when they assess a patient. The first thing to always do is stabilize a patient, ABC. You'll hear that all the time. When you do your ACLS, ABCs, that's airway, breathing, and circulation. You're always worried about, are they breathing? That's number one. They're not breathing, they're not alive. So that's airway. You need to make sure the airway is secure. Breathing, once again, make sure that they're breathing. And then circulation is a blood pressure. If the heart is pumping, there's no blood circulating. There's no blood circulating, the organs aren't perfusing. One of the main organs being the brain. So vital signs for this specific patient were heart rate 125. So that's tachycardic or higher than normal. Normally we see between 60 to 90, 60 to 100. That's within normal range, we say. Anything above is high, anything below is low. So bradycardic or tachycardic. Blood pressure 180 over 110, so that's high. As we know, a normal blood pressure is 120 over 80, so this was hypertensive. And SaO2, 78% on room air. RA is room air. And RR is respiratory rate 38. So basically, this patient looked like they were in distress. Their heart rate was high, their blood pressure was high. They weren't sitting well on room air. Room air means they're not attached to any nasal cannula or any type of oxygen to help them breathe. They're just breathing this 21% FiO2 ambient air that we're breathing as you guys are watching me breathe right now. And respiratory rate 38. Normal person, if you count how many times you breathe a minute, it's between 10 to 12. So this patient was obviously in distress, breathing very quickly and not protecting her airway. So this is kind of a real case. It is, but for HIPAA reasons, a few things were kind of changed around. Now, in this day and age, today, if this patient came to me, or last week, or even last month, if this patient came to me, a young person coming in, I would want to know a little bit more about their history to see do they have a history of any type of respiratory disorder, such as COPD, which is a disease that people do get if they've been smoking a lot. However, she does appear to be a little young for that disease. So other things I would think in my head would be, does this patient have asthma? That's definitely like one of the first things I think in a young patient with shortness of breath. We get a lot of asthma exacerbations that come to us. But one thing in this kind of day and age is COVID. She was at a party last week. She's not breathing okay, and people get exposed very quickly. So just differentials. Differentials are things that if I got called, when I do get called with these vital signs and this patient, I'm thinking already in my head, does this patient have asthma? Was this patient exposed to COVID? Does this patient have COVID? Does this patient have a blood clot in their lungs? That's another thing with the young female that I'm thinking, who's not breathing very well, who's kind of in distress. I'm thinking blood clot. There's a lot of risk factors for young people to get blood clots. And so that's definitely something that in my head, I'm like kind of trying to think. Other things I would think about would be just a normal bacterial pneumonia or a viral pneumonia. Sometimes you can get just community acquired pneumonias from the community. You're with somebody and they had mycoplasma pneumonia or just a random virus and you just happen to catch it. So then it'll be like a Z-Pack, something like that. Or other things could be if they had like a sinusitis or if they had an ear infection and that kind of, the pathway through the nose and the ears go to the lungs. So it all drains back. It's all kind of one connected airway. So then I'm thinking, does this patient have sinusitis? Does this patient have an ear infection? Because they're young, once again. So I'm not thinking broader like I would think if they were older. So those are kind of my differentials as I'm going downstairs to see the patient. And then what would you order next? So ordering next, that's also something that comes into my head because I need to be prepared to tell the nurses or or just kind of put the orders in the computer. Because first things are, you think something, then you need to order something to prove what you're thinking. You don't just randomly go out and order 100 things, because then the patient's bill will be like 1 million. So it's like, you need to narrow down your differentials, narrow down what your thought process is, and then order things according to that. One of my attendings always says, never order anything unless you're going to do something about it. So it's important. Like if I was to order an MRI head on this patient, it's like, why am I doing that? There's no logistical reason to do that. So in normal acute respiratory failures, what I do order would be like a blood gas. A blood gas is, it's when you take some of the arterial blood and you run it through what we call an iCalstat, an iStat, and it tells you the pH of the person. This is their acid-base balance to see, are they hypoxic? Have they been hypoxic? Hypoxic means without oxygen for a long time. This will tell you the CO2 or their carbon dioxide levels. The normal process of breathing is we breathe in oxygen and we blow out CO2. Sometimes people have problems where they cannot fully blow out the CO2 in their bodies, so the CO2 accumulates. When that happens, you will see it on a arterial blood gas. So that's something that I do order, a blood gas. Also, the blood gas will tell me their arterial oxygenation. And this is important to see if they're oxygenating their blood pretty much. So that's a test that I order, ABG. Next, I'll order a chest x-ray. A chest x-ray will help me see what's going on in the lungs. Is there a pneumonia? Is there an infiltrate? Is the airway open? Are there bronchospasms? Does it look like there's a mucus plug where you can't oxygenate the rest of the lungs? I usually describe to my patients, the lungs are like trees. So if you think about it, you have like the leaves above, and then you have your branches, and then you have further branches, and then you have leaves, which we call gas sacs at the end. So the branches are the bigger airways, and then the smaller branches are the smaller airways that they connect to leaves or air sacs. Air sacs are where the oxygenation happens and the CO2 gets diffused. If you have a problem in any one of those areas, the branches or the air sacs, then you're going to have problems. You're going to have problems with oxygenating. You're going to have problems with breathing. You're going to have problems with CO2. So I order a chest x-ray just to take a look. I order a blood gas. One thing that's very common that we do see is if something's wrong with the heart, it's usually wrong with the lungs. Heart and lungs go hand in hand. So I'll order EKG to make sure that their heart is beating okay. If their heart isn't beating okay, it will go back into the lungs. So I'll order an EKG, make sure that they're not having a STEMI or a heart attack. I'll order an echocardiogram to make sure that their heart is pumping okay. And then I'll order a full set of labs. Usually we do CBCs, BMPs, which are just to see, does the patient have a white count if they're infected? Does the patient have anything wrong with their electrolytes? But those are like my basics. My go-to would be those. So if a nurse called me right now and said, I have a 32-year-old female, history of XYZ, who's here for tachypnea. Oh, I'll also order a COVID swab. And then those are the first things that I'll order. Like, all right, give me a chest x-ray, a blood gas, an EKG, a COVID swab, BMP, CBC. I'll probably even test for parainfluenza or RSV or flu, depending on the time of year, but not now, because now it's not time of year. But those will be the first things that I'll order. Then I'll go down and I'll take a look. So before you know abnormal, you have to know normal. So when you look at this is a normal chest x-ray of a person. I mean, I guess you can kind of see that there's something there. But so when you're first looking at a chest x-ray, you have to know, is this PA or AP? This is AP. AP means anterior posterior lateral, from the anterior to posterior. If you're going to go PA, then that would be like more towards the side, and then you would see more expansion. You would see more of a heart border. So this is AP. The first thing you always check with a chest x-ray is make sure it's the right patient. So this is obviously not a patient. This is just a fake chest x-ray, but that you should always check. There have been problems sometimes where someone's looked at the wrong chest x-ray. But yeah, so anyway, one thing that when I was taught to look at chest x-rays, this always helped me. So it's a mnemonic with A, B, C, D, and E. When I'm looking at chest x-ray, the first thing I'm looking at is their airway, because ABCs, if they're not breathing, they're not alive. So look at their airway. This here is the trachea. coming down, and then it breaks off into the right and the left. So you can see the bifurcation right here where it breaks off into the right and the left. So A would be your airway. So something that I look at with the airway, is it straight? Is the airway midline? And it should be midline. And that's important, because if it's not midline, if it's not straight and it's more to the right or more to the left, I'm wondering, is there a mass that's pushing on it? Is there atelectasis that's making it go to one side or the other? And then I look to make sure that it's open. So it needs to have that, if you can see, it's kind of like a grayish shadow that needs to go throughout the right and the left main stem bronchi. So that would be your biggest branch off the tree. If you think about it like a tree, that would be like your first big branches coming off. And those in this patient or this chest x-ray, it all looks patent. It all looks open. I don't see any obvious plug, something that's stopping oxygenation from going through into the smaller airways or the smaller branches that would occlude the oxygenation from happening in the leaves or the capillary / alveoli. Then I look in the trachea, I trace down both the right main stem and the left main stem. I make sure it's midline. And then B would be breathing. So when you're doing breathing, you kind of are looking at the and the left, and then you're making sure that you can count how many rib spaces there are. Sometimes it could be a poor film x-ray if they're exhaling or inhaling on a certain different time. Let's say you shoot one chest x-ray today, you shoot one tomorrow, but on one they're on inspiration, one they're on expiration. If you think about it, your diaphragm moves up and down as you breathe in and you breathe out. So you see a different amount of ribs on each. So you need to count 10 ribs, and that would be like, it's a good film. It tells you that it's good in terms of their exhaling, and you can see everything. So that's when you count here. So you always count from the posterior aspect. It's kind of weird if you think about the rib cage. It's like a cage. So you count from the posterior or the back when you're counting. So it'll be like 1, 2, 3. You count the back part, not the front. Everybody always tends to count the front, but once again, it's like that. So you count from the back, and then you count 10 to 12 anywhere. Then you try to see, is one side bigger than the other. So I'm looking at my right here, I'm looking at my left here. They both look like they're pretty much the same. Generally, the right is a little more elevated than the left because of the liver, but otherwise, this is a good amount. So those are things that I look at for B. Other things that you can look at for B would be just trace down the branches to see if there are any mucus plugs once again, and you would see the mucus plug because if it just got cut off, that's a mucus plug. You can also look to see if there is a effusion. So if there's an effusion, then you won't see this diaphragm so rounded here, like this triangular area here. It won't be perfect. There will just be fluid here, and it will just be like a straight line. So the other things that I see with B. Also, another thing that I'll look at with B would be borders. So I'll trace the cardiac silhouette or the celiac border, the cardiac border. And this is important to see if a patient has cardiomegaly or a big heart on x-ray, because sometimes patients have heart failure or they have high blood pressure. The heart is a muscle. The heart is an organ. It is a muscle. So if it needs to work harder, it's going to pump harder. And just like any muscle, it's going to hypertrophy or get bigger. So if you see that, then that will kind of clue you into, oh, this patient must have long-standing high blood pressure. This patient must have heart failure. This patient must have had maybe some type of procedure done or something. But so I look at the heart borders. And this patient, it looks normal. It's not 2 to 1, or it's not half of the whole mediastinum, which you can clearly see. So that's B. That would be B. A was airway, B was breathing and borders, and C is circulation. So circulation, once again, or cardiac. C for circulation or cardiac. Cardiac, you look to see at the heart. Now, the general rule of thumb is it needs to be 1/3 to the right here. So that's the right side, and this is your left always. And then 2/3 to the left. So 2/3, it does look like it's mainly to the left, and there's a slight portion to the right. So that's kind of like what we do look at, and what you base it off of is your spine. So when you see the spine here, you base off 2/3 should be to the left, and then 1/3 should be to the right. And it should never be 50% of the hemithorax, or it shouldn't be, if this side was up to here, then that would be a problem. You'd be like, oh, that's cardiomegaly. So those are the things. It needs to be less than 50% of the whole mediastinum area. Other things for circulation, you can look at the top area here where the right main stem bronchus is, and then if you see like fluffy areas, then that would mean they're congested. It would be that their pulmonary vessels are filled with congestion, it's part of the circulation part. So that's something that we look at and see, circulation and cardiac. So that would be the C part. So you have your A, you have your B, you have your C, and then you have your D. D would be diaphragm. So here's the diaphragm. Now in patients with C, so diaphragm is a very, very, very important muscle for breathing. It's very important for you to inhale and exhale because it essentially, when you inhale, it helps you to take in your biggest breath that you can. And as you exhale, it helps to exhale as much air as you can. And this is important because sometimes if you have a restrictive problem, you can't inhale as much air. And if you have an exhalation problem like COPD, chronic obstructive pulmonary disorder, or asthma, they have problems exhaling. Their airways just close. So every time they try to exhale, their airways are closing and then all the air gets trapped. We call that air trapping. And we see that in COPD and we see that in asthma. So why this applies to the diaphragm, because over time, if they keep air trapping, it pushes the diaphragm. So when you start practicing or when you start reading about COPD or asthma, you'll be hearing about flat diaphragm. That's one of the major signs of COPD or asthma, a flat diaphragm. This person does not have a flat diaphragm, or this chest x-ray does not have a flat diaphragm. You clearly see that it has the circular shape, and that's normal. Also with the diaphragm, sometimes one side could be higher than the other, and this could be because of a prior surgery they had. So the diaphragm is innervated by C1, cervical 1 nerve, cervical 2, cervical 3, 4, and 5. And that's in your cervical spine area. So if somebody went for a surgery, they got into a MVA collision, a motor vehicle accident, car accident, their head went like that, and then they snapped their spine, or they had surgery in their spine for stenosis. Maybe they had some type of growth at birth and they needed surgery on that area. If you manipulate those nerves, one side of your diaphragm could be more elevated than the other. And we do see that. And that has implications in breathing. It makes you breathe more quicker, because you can't take in that big, deep breath. Like I said, the diaphragm is important for pushing down to take in as much as you can and push out so you can exhale as much. If somebody's diaphragm is elevated, they're going to be breathing in, breathing out, breathing in, breathing out, trying to compensate for the fact that they can't take in a large, deep breath. So that D is diaphragm. So I'll look at the diaphragm. And then one more thing I'll look at in the diaphragm is I'll make sure that these diaphragm borders are sharp. Because remember I told you if it's not a triangle like this, then that means there's fluid. That's something you should check. So you have your A, airway; B, breathing; C, circulation or cardio; D, diaphragm. And then E is kind of everything else. E would be if the patient's intubated, you'll see an endotracheal tube here. If the patient has a central line, you'll see a line coming in. If they have a line here, you'll see a line coming in there. If they have a chest tube or something, you'll just kind of see it. So it's kind of everything else, we call it. All right, now you know normal. So does this look normal to you? So this is a patient who had COVID. Let's say this is our 32-year-old. Just kind of looking here, you can see, first of all, that there's a tube. First things first, airway. You're looking in the airway. You can see that there's a tube going in, so the patient's intubated. Then you see a bunch of spots here. All that spot is congestion, and it's just COVID remember we talked about the lungs being like a tree and has your branches, then you have your smaller branches, and then you have your gas sacs or your leaves. All of the leaves or the gas sacs are filled with stuff. They're filled with debris, bacteria, the virus. And that's what happens in COVID. So this is a severe case of COVID. You see that there's no black. Black means air. Anytime you see black on any imaging, whether it's a CT, a chest x-ray, it's an MRI, it's air. So you want air in your lungs. But here, there's barely any room to breathe. And you can also kind of see the heart is really big. All right, so let's talk a little about, does this patient end up having SARS-CoV-2 or COVID-19 pneumonia? So let's talk a little bit about it. So the virus, SARS-CoV-2, It enters the body primarily through the nose or even your eyes and your mouth. That's why they say you should be wearing a mask. Technically, everyone should be wearing a face shield and to protect their eyes, and then the mask to protect your mouth and your nose. That's why you should be wearing it like this and not like this or not like that. And they say you get it within 6 feet. That's what all the studies have proven. If you're 6 feet in contact, the droplets will reach each other, will reach the other person. Sorry. All right. So this is a little bit about the virus. First, it's an RNA virus. It binds onto the ACE2 receptors. Now, the ACE2 receptors are found in abundance within the trachea and in the lungs. That's why SARS-CoV-2 is primarily a respiratory virus, because all those ACE2 receptors that the virus needs to bind is found throughout the lungs. So the virus loves the lungs. Other places it's found would be the heart, which is why it causes cardiomyopathies, it causes heart blocks, it causes atrial fibrillation or different arrhythmias. Other places ACE2 receptors are found is the kidneys. It loves kidneys. So kidneys, heart, and lungs are your three main ones that the virus just loves. So when the virus finds these ACE2 receptors, it enters the cell body and it releases its RNA. Once the cell gets a hold of the virus's RNA, it replicates that. It replicates the virus's RNA over and over. As it replicates it, it packages it and releases its particles. So if I'm the cell, I'm getting this, and this is the ACE2 receptor, is getting the virus. I'm churning out these virus particles and I'm releasing this from the cells into the body. So over and over, it's just replicating and replicating until you get really sick. So to this day, we don't have many treatments, which is why this is a very severe and scary disease. It's still bad. We don't have a cure. We have things to kind of treat, but there's no cure. Prophylaxis is a vaccine. So everybody should definitely get their vaccines. Now, treatments that we do are steroids. Steroids, the reason why steroids helps is because it decreases all the inflammation, a lot of the inflammation, because a lot of this is cytokine mediated. Oxygen. The problem here, as you can see, there's no room for oxygenation. The lungs can't oxygenate on their own. So you try to hook them up to a ventilator. You can see here that there's the ET tube, the endotracheal tube. They're hooked up to a ventilator, and and then we paralyze them. So we sedate them, meaning they don't work to breathe on their own. We sedate them very well to the point where they're on 2 drips for sedation, just continuously going. And then we paralyze them, meaning we put them in a medically induced coma. And this is to rest their body and rest their lungs. Pretty much this is for oxygenation to help them breathe. If you can see on the x-ray, there's no room for oxygen. So their lungs are taking a rest and the ventilator is doing the work for the lungs. Now, when this fails, we have a salvage method called ECMO, extracorporeal membrane oxygenation. And that's like a bypass meaning the blood is getting circulated. The point of the lungs is to bring the body oxygen and take away the CO2. This would be a machine that's doing the work of the lungs for them. So it's lungs outside the body. And that is what ECMO is. And that's what we do have a lot of our patients on with COVID, severe COVID. So yeah, that's oxygen. Your main goal is to oxygenate these people. You need to oxygenate them. Remdesivir. Now, remdesivir, Regeneron, and tocilizumab. These are hot things that you'll hear on the market. I mean, we do remdesivir. It hasn't really had a mortality difference, but it has shown in studies decreased amount of days of oxygen therapy, days on the vent, days for treatment of COVID. It decreases the duration of treatment. At least the studies have shown. Regeneron, this is the bamlanivimab, though it's the Trump treatment, the whatever cocktail that he got, that's the Regeneron one. So that's given as outpatient, as a cocktail therapy. We give it to patients who meet a certain criteria. You cannot be on oxygen. You have to be older than a certain age and you have to have a certain comorbidity. So if you check off all those boxes, then prophylactically you will get Regeneron. And the goal of Regeneron is to make you not get as sick. So it's a good option. I have referred a lot of my patients for Regeneron, and some do very well on it and some don't do as well. So it's kind of like a hit or a miss. Anecdotally, personally, I have found studies have shown that if it's given in a timely manner. I think that's the biggest thing with the ones that I have seen failed, is it's not given in a timely manner. So you need to give it, like, if I start having symptoms today, I need it now, or I need it tomorrow, ASAP. Tocilizumab is another monoclonal antibody that we do give in the hospital for patients that are on the ventilator. If they're having a high amount of inflammation in their body, the thought behind tocilizumab is it binds to the interleukin 6 or the IL-6, and it kind of supposed to stop really the cytokine storm. So this is, here you can see this is a normal lung, and then this is a COVID-19 associated acute respiratory distress syndrome, or COVID-19 pneumonia lung, essentially. So we spoke about how it loves the lungs because it has the lungs and the trachea are full of ACE2 receptors. The virus binds all over the lungs, and it causes, when the virus is there, it's foreign to our bodies. So our body then sends a bunch of macrophages to come and try to kill it. Macrophages are the cells that eats the garbage, eats the bad stuff. So you get a massive macrophage infiltration. And then what happens is the body then reacts to what it just sent by sending out cytokines. And one of the biggest cytokines that we have found is IL-6 or interleukin 6. Another one is TNF alpha. There's IL-1. There's interferon gamma. A lot of these we're finding, but IL-6 seems to be one of the biggest ones, and that's what tocilizumab binds to. So the cytokine storm happens, and then it destructs all the cytokines, kind of kill the type 2 alveolar cells. You have type 1 alveolar cells, and you have type 2 alveolar cells. Type 2 alveolar cells are necessary in the body for a molecular, this thing in our lungs that we call surfactant. Surfactant is needed for kind of the lungs to move, and for the alveoli or the gas sacs, the leaves we were talking about, to open to get the oxygen, and to close to blow out the CO2. So if you don't have that movement because you don't have surfactant, then your lungs aren't moving, they're stiff. And that's kind of what we were seeing, or we are seeing in COVID. You lose that movement. If you lose that movement, you lose oxygenation. So it's all kind of like a vicious cycle. Another thing that steroids do is it stops, or it should decrease the inflammation. So essentially it should decrease the cytokine storm. This is kind of just talking about what we just spoke about. All right, so that's a little bit about COVID. If you guys have any questions about the case we just did, you can put in the comments, and we'll get around to it. Another interesting thing that we do see, and this is kind of like another case that I had, it's another type of thing that we do take care of in the ICU. So the same patient, we'll say 32-year-old female, history of diabetes, hypertension, comes to the ER for shortness of breath. It's the same exact case, but this is a different pathology. So like we spoke about, in my head, if I get this call from the ER and I'm like, okay, this patient is tachypnic, this patient vitally is not doing okay, she is in respiratory failure. So let's talk a little bit about respiratory failure. I was telling you guys what I do order is an arterial blood gas. And this is the way that you always read arterial blood gas. First, you have your pH, then you have your CO2, then you have your arterial oxygenation, and then you have your bicarb. So the pH will tell you the body status as to if you're acidotic or if you're alkalotic. And this is very important because it has to do with a bunch of different things. Cellular function, are you going to hyperventilate? Are you going to hypoventilate? Yeah, so that's important. Also, two things that I forgot to mention earlier is oxygenation is one part and ventilation is another. So oxygenation is the process of getting oxygen into your body, into your blood, into all of your organs. Ventilation is the process of blowing out the CO2. So I did mention that you breathe in O2 and you breathe out CO2. One process is oxygenation, one is ventilation. Both are necessary for life. So CO2 is the ventilation that we look at, and then the PaO2 or the arterial oxygenation is the oxygenation part. The bicarb kind of helps with the acid base part to see if this is respiratory induced or this is metabolic induced. So hypoxemia and hypoxia, those are two words that people get confused, or people just kind of synonymously use, interchange, but they're different. Hypoxemia is defined as a decrease in the partial pressure of oxygen in the blood, where hypoxia is the reduced level of tissue oxygenation. So hypoxemia and hypoxia, sometimes they don't exist at the same time. Hypoxemia can cause hypoxia. Hypoxia is defined at a cellular level if the body goes through glycolysis because it has the oxygen to do so, or if the body will produce lactic acidosis through a Krebs cycle, as we remember. certain molecules, certain cofactors to go through one, or you end up going through the other, which is lactic acid. And if you get lactic acid in your body, that's pretty detrimental to the body. The body does not handle lactic acidosis very well, and that would make you more acidotic. If the body finds lactic acidosis, the heart works harder to pump because lactic acid makes your blood vessels vasodilate or get bigger. So then your heart's pumping harder to keep up. Yeah, so respiratory failure, that's a huge thing whenever you will see it in the future, hypoxemia versus hypoxia. There's different causes of hypoxemia. One is a VQ mismatch, then right to left shunt, diffusion impairment, hypoventilation, and low inspired PO2. So low inspired PO2, this one's kind of interesting. The partial pressure of oxygen is the barometric pressure depending on where you are in Earth / where you are even in the US. If you're gonna travel up to like a mountain peak, then it will decrease. So you will actually be hypoxemic because the barometric pressure that you're actually inhaling is not 760 millimeters of mercury, is different up there. And that just happens. If you've heard of high altitude sickness, if you've heard of people that just get short of breath as they go to a mountain, this is the reason why the barometric pressure is different. Hypoventilation. So I told you guys that there's oxygenation, there's ventilation. If you're not breathing because overdosed on drugs, you took a benzo or Ativan, those impair the respiratory drive. So you're just not breathing. You're fine with oxygenating, but you're not moving your muscles to exhale. That's hypoventilation. One of the most common causes of hypoventilation is medications that cause respiratory paralysis or just kind of work on the nervous system, and that kind of will stop the triggering for your brain to make you breathe in and breathe out, because there's chemical chemoreceptors that the body responds to. But if you depress them with alcohol, with the GABA agonists like benzos, those can stop you from breathing essentially. Diffusion impairment. Diffusion impairment would be like a blood clot. So if you think about, if you think of like a hanging ball and then like a capillary under, if something is stopping that blood from flowing, then it's a diffusion impairment because the blood can't flow. A clot will stop blood from flowing. A mucus plug. So sometimes we have like goobers, mucus that just get stuck into balls, and then you swallow them, and then you think about it going into your lungs and just kind of diffusing into your capillaries, it's going to stop the blood flow, or it will stop it will stop breathing. It will stop air from coming in and coming out like a foreign object. When children swallow batteries, when children swallow coins, when adults sometimes swallow coins, don't ask me why. If it gets dislodged into their like right main stem, then it stops oxygenation. That's a diffusion impairment. There's diffusion is not happening essentially. Right to left shunt. Sometimes patients are born with like large PFOs or patent foraminal ovale, or they're having it can be a congenital reason. Other causes of right to left shunts could be atelectasis, meaning the alveoli are just not opening. They are closed because there's just no oxygen going into there, and they just need some CPT or chest physiotherapy, or they need to use an incentive spirometer and just open up the back of their lungs. Maybe they've been bedbound for like a year. They've been bedbound for 30 days. There's just debris, particle, bacteria from a prior pneumonia there. So then if they're not getting oxygen, if the leaves or the gas sacs aren't getting oxygen, they're not going to oxygenate the capillaries that are running under. So if they don't oxygenate the capillaries that are running under, then the capillaries are just going to carry unoxygenated blood. So if you think about it, it's kind of like a mechanism tree here. So the oxygen needs to go, like I was telling you guys, like a tree. It goes through the branches and smaller branches. As it goes through the smaller branches here, this is like an alveolus, and this is the capillary around it. So if you have debris stuff in here into the alveoli, then these capillaries are not perfusing properly. It's just going to give deoxygenated blood, deoxygenated blood, deoxygenated blood. So that would be right to left shunt. Other things could be VQ mismatch. Now, VQ mismatch could also be a blood clot. It could be atelectasis. It could be pneumonia, meaning you're preferentially ventilating and oxygenating one area of the lung instead of all the areas of the lung. The lungs are very complicated in terms of their anatomy. You have an upper lobe, you have a middle lobe, and you have a lower lobe. And those lobes are further broken down into little segmental areas. The left as well. If something happens where you have a pneumonia in one specific lobe, that specific area is not getting ventilated or oxygenating, it's causing a VQ mismatch. So that's something that we do look at too. So that's kind of like this is kind of a general idea of what I do on my daily basis of acute respiratory failure. I've been seeing a lot of COVID, and since it's so relevant, I figured that would be the case that I spoke about today. Just to kind of describe the pathophysiology behind COVID. Now, COVID affects every organ, unfortunately. We do see a lot of long-term effects in terms of neurological problems. Now we're seeing what we call COVID-induced encephalopathy. We're seeing a lot of depression. We're seeing blood clots all over the body. We're seeing vasculitises. We're seeing skin manifestations with derm, kidney failure, heart problems. It kind of affects almost every organ. But I do know that we do have some time now for questions. I took actually a lot of cases, but I didn't realize that I talk a lot and my time would just kind of fly by. But like I did say, I do talk a lot about my cases on my Insta. I have like a lot of stories that I talk about what I do see. So if you guys are interested, if this did interest you, definitely do follow me. Like I said, I had a lot of cases. But here's my contact information if any of you guys do want to reach out. My email address, my Insta, and then a website, which I haven't really updated in a long time. But a journey of 1,000 miles begins with a single step. I applaud each and every one of you guys for being here today, taking your time out of your day to learn about what I do. We need more doctors. It's a shortage. And with everything happening today, the pandemic, this and that, there's going to be a lot more problems in the day. So we need good doctors, good people like you guys. If you have any questions, I think you'll have them for me.
One of the questions, like going back before your case studies, before med school even, going into your undergrad a bit, could you talk about your undergrad journey and like what you majored in? That was a big question I saw.
Yeah, that's a great question because you can technically major in anything and still go into medicine. You can major even in dancing and still go into medicine. So I was a typical basic person and I did psychology as my minor and then biology as my major. So it was pretty basic, but don't let any type of major stop you at all.
Another one, more about the case study. Someone asked I'm sorry, I'm about to butcher this, the TACHP or YPNIC. Is that the same as hyperventilating?
Yeah. Yeah. Tachypneic is defined. Tachy means fast, and then the PNEIC is actually breathing. Okay. A lot of our terms come from the Latin and the Greek, what you'll see. But yeah, it's just breathing quickly, and that could be hyperventilating because when you're breathing quickly, essentially you're breathing out your CO2, which is hyperventilating. People who have panic attacks, they unfortunately do that.
Yeah. And finally, just to like wrap it up, if you what's one major piece of advice you could give to anyone looking to pursue medicine and specifically ICU, like working in critical care?
I would say don't let a score stop you. I went to the Caribbean from a medical school. I would not trade that at all. There were a lot of biases against it. I don't think it's a bad option. I think if that's an option that's granted to you, then one should be blessed for that option. It's a means to a way of what you want to get. It's not like looked down upon by any means. I'm exactly where I want it to be. So I would say don't let a score stop you and just work hard. Honestly, it seems like what the small things that you're doing today don't add up to something bigger, but it does. When I was in med school, when I was in undergrad, I was like, why am I doing this? Why does glycolysis matter? But then here I am today, like, oof, if they don't go through glycolysis, then they're going to go through like lactic acid. And that's going to cause like XYZ. everything you're doing today has a meaning, and it will get you to where you want to be.
All right, that was perfectly worded. Thank you so much for sharing these wonderful case studies and for sharing all your advice. Again, if you guys had any additional questions or if you wanted to see more of what she's up to, more case studies, go ahead and check out that Instagram. It's right up on the screen. And I hope to see you guys all next week. Thank you so much, Dr. C, for giving up your time. We really do appreciate this learning opportunity.